Thank you very much for your time this morning. I'm going to talk about health inequalities and its relationship to the workplace, and indeed, to be honest, its relationship to not being in the workplace, which is probably more important in this this discussion. There are huge, and I'm afraid increasing health inequalities across the population that we are privileged to serve in this country. There's a 7-year life expectancy gap between the better off and the worse off nationally. And worse than that, in terms of if one measures disability-free life years, the difference is actually 17 years between the best and the worst off, according to the Marmot Review. That's the best and the worst off, but this rather complicated graph shows each dot is a different sort of small geographical area, and it shows that actually we're looking at an extremely fine grain in terms of health inequalities and class across the country, from the very best off to the very worst off. And actually, if you're very, very, very well off, you do better than somebody who's not quite so well off, but quite well off, who'll do better than somebody who's middling, who'll do better than somebody who's a little bit harder, who does better than somebody who's who is in considerable poverty. So there's a huge variation in both life expectancy and in disease-free life years across the population we serve, which is very finely grained. This is data from Essex, and actually shows what are the relationships within the index of multiple deprivation, which is the score that people use in order to look at deprivation and look at a whole range of things associated with it, and health. So this looks at the health and disability score within the index of multiple deprivation, then plots it against other different parts of that score, and probably not surprising to people in this room, the greatest relationship, the strongest relationship, is between employment and health. The second strongest relationship is between income and health, and the third between education and health. And actually, if one looks at the other elements within the IMB score below that, the relationships are much, much weaker, but it's very clear that there are very strong relationships between employment and health. That's been recognised for a very long time. The problem was historically, actually, do people fail to maintain employment because they are unwell? And when you look at a cross-section of the population, what you're seeing is the people who are unwell can't keep the jobs. Or do people who lose their jobs become unwell as a result of losing their jobs? And that was quite a difficult thing to nail through the 80s, and I'll come back to that later. This is about people who have got a job, people who are in work, and this is old data now, but it's really classic. This is the Whitehall study. One of the early Whitehall studies, which were conducted in the 60s by people at University College in London. And what they did, they looked at the people who were employed by the civil service at that time, 60s, 70s, and they followed them up for years and years. Now, actually, when one thinks about inequalities, this is a group who, while they were in different sort of pay grades and administrative roles, they all had a stable job and probably a job for life in those days. So actually, to compare this to an unemployed person, misusing substances on a council estate in Newcastle, to any of these is probably they're probably right off the scale. But what they actually did was they looked at every different grade within the civil service, and this happens to be followed up for 10 years from cardiac death, and they measured every possible risk factor that you could think of: exercise, smoking, blood pressure, anything. And basically, they followed them up for year and year and year and year. The sort of the speckly lot there, the administrators, are kind of your Sir Humphreys from Yes Minister, for those who remember it, and the guys who would be in the other would be the guy who operates the lift or parks the cars. And basically, they found the difference between Sir Humphrey and the guy who parked the car in controlling for age was 2.7. But just controlling for age. When you brought all those other risk factors in, the smoking, the physical activity, blah, 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 it only drops 2.2. So actually, the majority of this difference between these groups is not due to the lifestyle risk factors. It's due to something else, which has been put down to material deprivation, but also in the workplace, it's been put down to control, the sense of control that you have over your job and the stress that results from that. There is kind of the mythical archetype of the high-stress executive, but actually the high-stress executive has got a very positive feedback, is in a very positive role, and actually the person who really feels the stress is the person who's told what to do, has very little control over what they do, and has no influence on the structure and is basically done to. So I think that people's sense of where they are, their control at work, the stress they feel is a key driver in this, but one has to interpret that very carefully. But certainly there's a key link between material deprivation and health inequalities in terms of outcomes for death, which is not necessarily related in the Whitehall study to the lifestyle risk factors that we often look at. This is a bit of a spot the difference competition from Essex. So you've got to spot the difference. This is actually, this is what's called the Bathside Bay development, and I know there are a couple of people from this part of the country, that part of the country around here today. Basically, it would have been, it's probably not going to happen now, but it would have been the second largest container port in the country had it carried on. And the biggest container port in the country is actually where this curtain is, which is kind of Felixstowe, which is literally a spit away from it. In public health, we had to do a health impact assessment of this development. And while at the first we thought it was going to be about noise, it was going to be about light pollution, the reality is the main impact of having this would be a huge positive impact on the population we serve in terms of bringing new jobs into the area. And I think in the area where at the moment we do have to be very clear that the key thing that we can do in the local authorities, in district councils, in county councils, and indeed in the business sector, is to try and stimulate growth, to stimulate regeneration into these areas, because that in the end is what will fundamentally improve the health of the population who live in these areas, assuming they have the right skills and abilities to take on these posts, which we also need to be clear about. So I'm going to go back to the question of, are people out of work because they're sick, or do people get sick because they lose their jobs? And this was actually very, very difficult to nail down. And one of the key pieces of work that shed light on this actually happened entirely by chance in the 1980s. Norman Beale was a GP who lived in a place in Wiltshire called Carn. Does anyone remember Harris's pies? I do, I'm afraid, but Harris's processed meat and pies. Well, somebody does. So somebody's already eaten their lollipop and remembers the processed meats and pies. But basically, this Harris's factory was in Carn in Wiltshire and employed the vast majority of people in the town. The main problem with Norman Beale when he started to do studies on this population was he couldn't find a control group that wasn't actually affected by the closure of the processed meat factory. And what he did was he could look at the impact on a whole range of different measures of health on that population as they were under threat of losing their jobs, as the security they'd had for years disappeared, and then on into to losing the jobs and to unemployment. And what he found was this happens to be attended to hospital as outpatients, but there's lots and lots of different measures that were looked at, that both while there was a threat of unemployment and following unemployment, not just in the employees, but in the employees and their families, there was a deterioration, a worsening in every measure related to health, in mental health, in physical health, in doctors' appointments, in serious conditions, in mortality. Everything that he looked at, there was significant changes, significant deterioration in the health of the population as a result of losing the job. So it's very clear that it's the unemployment that leads to the poor health, not the other way around. Going back to what people have said before in terms of role of the workplace, in terms of the new white paper, the new strategy for public health, employers from all sectors, as we've heard, should look to support the health and well-being of their staff. And there are a number of ways in which this can be done. There are a number of key lifestyle risk factors that can be addressed through the workplace. And I'm sure these are things that will be discussed later on. Smoking remains a key issue, and there's good evidence that can be addressed through the workplace. Physical inactivity, poor diet, and high alcohol consumption. And again, I think later this morning, later today, you're going to hear much more about the economic arguments for doing this, which are actually crucial. I've been told to sort of steer rather clear of the economic arguments. But I did, in terms of the national picture, the NHS health inequalities is costing us £5.5 billion a year. And it's costing businesses £31 to £33 billion a year due to lost productivity in terms of people in the workplace. What I did do is I actually plugged in, if we just did the nice physical activity stuff in Essex County Council, so for the employees of that fairly big organisation with nearly 8,500, not going to go through it in detail, but just as a taster, if you do that, if you put in a comprehensive range of interventions to improve physical activity in that workforce, the sums add up so that you actually can save £1.25 million a year in costs, in revenue costs. And actually that's in times of very hard pressure on public services, in times of a requirement to really look after the public purse. I think it's quite criminal in every way, and quite morally wrong in every way not to be seeking that saving, let alone seeking to improve the health of the population we serve. I'm going to shut up now. Thank you very much for your time and attention this morning. Thank you.